All right, hello everyone. Welcome to the McMaster Health Forum. I'm James, and I want to thank you for joining us here today for our third webinars from our QE scholars for this term. We have one more after this. It'll be next week on Wednesday at 3 o'clock. So an agenda for today's webinars. I will provide you a quick little summary of the McMaster Health Forum. I will give you a quick little rundown of our current Queen Elizabeth Scholarship Program, a summary of our new Queen Elizabeth Scholarship Program, and then I'll introduce you to our two presenters, Chloe and Sabrina. Chloe went to Australia and Sabrina went to Malawi in the summer of 2018. So the McMaster Health Forum is a leading hub for improving health outcomes through collective problem solving. We aim to harness information, convene stakeholders, and prepare action-oriented leaders, and act as an agent of change by empowering stakeholders. The Queen Elizabeth Scholarship Program is run by a partnership between the Rita Hall Foundation, Community Foundations of Canada, Universities Canada, and individual Canadian universities. The purpose of the program is to activate a dynamic community of young global leaders across the Commonwealth to create lasting impacts both at home and abroad through cross-cultural exchanges encompassing international education, discovery and inquiry, and professional experiences. The version of the Queen Elizabeth Scholarship Program that's offered here at the McMaster Health Forum is called the Strengthening Health Systems. Our scholars will contribute to strengthening health systems and become part of our large and growing network of health system leaders. This program, from which our two scholars will be presenting today, is ending this year, but we have been awarded a new scholarship program. We are one of 20 Canadian institutions to be awarded a new Queen Elizabeth Scholarship Program. It will run from 2018 to the end of 2021. This new program is called the Queen Elizabeth Scholarship Program in Strengthening Health and Social Systems. There are it's mainly the same program with a few differences, so I'll just highlight those differences now. First of all, the location of the internships has changed. The old program, we could only send students to Commonwealth countries or involve students from Commonwealth countries. Now we can all expand that to include low and middle income countries. Because of this, our partners have changed. We have the same partners that we had in our previous program. We've added two new partners, one in Colombia and one in Lebanon. The focus of our internships have slightly changed. We have expanded beyond health systems and are now also including social systems. And because of this, the eligible McMaster programs have changed slightly. All of the same undergraduate and graduate programs are eligible. We have added now the Arts and Science undergraduate program as an eligible program. And the number of opportunities has changed. In our old program, we hosted or sent abroad 61 students. In this new program, we will only be sending or hosting 24 students, so cut by about a third. With that said, here is the scholars from our current, now ending Queen Elizabeth Scholarship Program. Our first cohort, which is on the screen now, primarily went away or visited us in 2016. Our second cohort, which was quite large, 22 students, primarily went away or visited us in 2017. And our third cohort, which is also quite large, 25 students, of which our presenters are part of this cohort. These students primarily went away or visited us in 2018. As we record this webinar here in the fall of 2018, we have 5 students currently abroad. With that said, our first presenter today is Chloe Gao. Chloe is an undergraduate student in the Bachelor of Health Sciences program specializing in child health. She's developed an interest in supporting evidence-informed policymaking and service user engagement in healthcare reform. Through her internship, Chloe hoped to gain further insights into the processes by which research evidence can be translated into the implementation of regulatory policies which are conducive to improved population health outcomes. So with that, please let me introduce you to Chloe.
Thank you, James, for the introduction. Before I go into my presentation, I just wanted to do something called a land acknowledgement, which I noticed was a custom in Australia. So my very simplified explanation is that this acknowledgement essentially serves to recognize the original inhabitants of the land where a certain gathering takes place. And although saying these words don't in any way remedy past events, they do spread an awareness of Indigenous presence, ownership, and land rights in everyday life. So in keeping with this, I'd like to acknowledge the traditional territory of the Haudenosaunee and Anishinaabe peoples, and I'd like to pay my respects to their elders past, present, and future. I'd also like to acknowledge the traditional inhabitants of the land on which I completed my internship in Sydney, and that's the Gadigal people of the Eora Nation. So I'm very thankful for the opportunity to live, work, and learn on these lands. So here's just a brief overview of what I'll be talking about today. I'll start off by introducing the Sax Institute, which is where my internship took place. I'll then explain the historical context behind each of the 3 main projects that I undertook at Sachs. I'll then give a high-level summary of the projects I completed during my internship, as well as its relevance and impact to health system strengthening. And finally, I'll end things off by highlighting some of my favorite personal experiences of my trip and of my entire life so far, and share some of my future plans, which QES has undoubtedly shaped. So it all started when I got on a plane to the other side of the world, as all good stories start. I was really looking forward to the opportunity to learn about and contribute to health system strengthening work with the Sax Institute. And I was also super excited to immerse myself in Australia's outdoor lifestyle and huge distance running culture, which is one of the main reasons why I chose to complete my internship in Sydney specifically. And the picture on the left, don't be fooled by the smile. I actually started crying immediately after that picture was taken because it hit me that I'd be leaving for 3 months. But I'm glad that my parents pushed me out the gate because it was the best thing ever. So, yes. So now just moving on to a brief introduction of the Sax Institute. So it's a not-for-profit organization that aims to bridge the gap between researchers and health decision makers. So its mission sounds very similar to that of the McMaster Health Forums. So the Institute is comprised of several divisions, and I've listed some of them above. And each of them pursue a different line of work, but are united under this common goal of supporting the use of research evidence and the development and implementation of policies, programs, and services. So during my internship, I was mainly based in the knowledge exchange team, but I also contributed to some work with the SEARCH team. And SEARCH, by the way, stands for the Study of Environment on Aboriginal Resilience and Child Health. So before I start talking about the specific work that I was involved in, I just wanted to give you all an overview of the historical context around which my projects were centered. So Aboriginal and Torres Strait Islander people are the first inhabitants of Australia and are one of the oldest surviving cultures in the world, which really speaks to the richness and depth of its cultural history. But if we look at Australia's past with openness and honesty, it really reveals that the colonization of Australia by European settlers has led to this concept called stolen generations. So where many Indigenous children were forcibly removed from their families after colonialistic government policies were implemented. So the generations of children removed under these policies became known as the stolen generations, and this removal broke important cultural, spiritual, and family ties because children were essentially placed in these institutions or with white families where neglect, cultural shaming, and other forms of abuse were pervasive. And it's really important to note that the damaging effects of this removal extend far beyond the individual child who was directly removed. So the trauma experienced by these children impacted their families, their community dynamics, and their future relationships with their own families. So its effects have been deemed to be intergenerational in nature. And this idea of stolen generations has left this legacy of intergenerational trauma and loss on the lives of Aboriginal and Torres Strait Islander people, and which is evidenced by the large disparities that exist across several quality of life indicators such as health, education, employment, and housing. And because most of the people, well, I guess all the people watching my presentation are likely Canadian, this history closely mirrors Canada's residential school system, which was established by government to forcibly assimilate Indigenous children into the dominant Euro-Canadian culture and has also caused much intergenerational harm and present-time health and social inequities. So now that I've outlined the historical context of my work, I'm going to talk about the specific projects that I was involved in at the Sax Institute. So during the course of my internship, I assisted with projects with both the knowledge exchange team. So those are 2 rapid evidence scans that address different pressing health issues. And I also assisted with a community feedback report with the SEARCH team. And this was for an Aboriginal community-controlled health service. And I'll definitely go into more detail about these projects as my presentation goes on. So just starting off with the work I completed with the knowledge exchange team. So before I talk about the rapid evidence scans that I helped to write, I just wanted to give you all like a definition of what a rapid evidence scan actually is, because it definitely wasn't a part of my common language when I first started working at the Sax Institute. So a rapid evidence scan is a concise summary of evidence that aims to answer a specific policy question presented in a policy-friendly format. So it's very similar to the rapid response program here at the McMaster Health Forum. So when a requester, which are often decision makers across government and non-government agencies, so when they commission a review from the Sax Institute, there are a few preliminary steps before the actual writing can take place. And one very important preliminary step is the knowledge brokering session, which is essentially an in-person meeting with a representative from the requesting agency and a knowledge broker with experience in both the research world and the policymaking world. And this knowledge broker is then responsible for clarifying the relevant policy issues and translating them into researchable questions that researchers can easily work with. And although the research part of the process doesn't typically occur in-house, just as an aside, the Sachs usually commissions external researchers to take on the writing after they themselves facilitate the knowledge brokering session. The knowledge exchange team actually received 2 rapid requests during my internship where time constraints meant that all the work would be conducted in-house. So I had the opportunity to be involved in the process. So the first rapid evidence scan that I was involved in examined diabetes programs for Aboriginal people. So in Australia, it's known that Aboriginal and Torres Strait Islander people experience disproportionately high levels of diabetes compared to their non-Indigenous counterparts. And here are just some statistics illustrating that fact. And you can see that the percentage of people reporting diabetes is significantly higher across all age groups for the Aboriginal and Torres Strait Islander population. So because of this health gap, the Aboriginal Chronic Conditions Network Executive at the Agency for Clinical Innovation, or ACI, which is a statutory health organization in New South Wales, so they identified diabetes as a priority area for improving health outcomes for this population. So after convening a knowledge brokering session with a representative from ACCN, this specific review question surfaced. So what initiatives for diabetes care that have a focus on Aboriginal populations have been implemented in Australia? So to answer this review question, systematic searches were conducted, which generated various papers and reports describing a range of programs implemented for Aboriginal and Torres Strait Islander people diagnosed with diabetes in Australia. So I'm not going to walk through all the findings in detail, but some of the most common program target areas included educational interventions, which encourage people with diabetes to make lifestyle and dietary changes, screening interventions to promote early identification, treatment approaches, self-management support, case management and care coordination to support continuity of the services received, which is especially important because diabetes is a chronic condition, and foot care and care addressing other physical complications associated with diabetes. So some program features that were deemed to be important by service users and service providers alike across the literature include holistic, integrated, and culturally competent care, as well as involving Aboriginal health workers in the design and delivery of care, which also improves the cultural competence of care. So the second rapid evidence scan that I was involved in explored transfer of care programs for Aboriginal people. So Aboriginal people in Australia face higher rates of hospital admissions as well as chronic illnesses that lead to these hospital admissions compared to non-Aboriginal Australians. And again, just some statistics illustrating that fact, and you can see that it's significantly higher amongst Aboriginal and Torres Strait Islander peoples across all jurisdictions in terms of hospital admissions. So since transfer of care initiatives aim to streamline transitions between acute care settings such as hospitals back to primary care settings such as GPs and community-based clinics, the ACCN similarly identified this as a priority area to improve health outcomes for Aboriginal people. So Another review question then surfaced based on this health issue. So what promising transfer of care initiatives with a focus on Aboriginal populations have been implemented in Australia? So once again, I'm not going to walk through all the findings in close detail, but just a brief overview. So we identified several papers and reports that explore transfer of care initiatives tailored towards Aboriginal populations in Australia. So it's important to know at this point that only one of the papers that we identified actually explored a transfer of care initiative from an acute care setting to a primary care setting explicitly, whereas the majority of the papers actually focused on care pathways, which is different because it's more complex and it involves several providers across several different care locations within a single treatment plan for one person. So but we chose to include these papers as well, even though they didn't explicitly address a review question, because mechanisms to support transfer of care were mentioned, so this information was very important for us to capture as well. Finally, one paper identified the question of early intervention to prevent premature self-discharge or discharge against professional advice. So in this paper, it was found that improving cultural safety would reduce premature self-discharge, and this in turn, obviously, is conducive to successful transfer of care. So across the papers, several barriers and facilitators were also identified. So barriers included system complexity, so having long care pathways involving multiple providers across several care locations was definitely an identified barrier. So as well, unclear care pathways that are not consistently promoted to healthcare providers. Inadequately trained and coordinated workforce where providers are not or do not have a good understanding of their own as well as others' roles and responsibilities. And interestingly enough, in our synthesis, it was found that practitioners were often unaware of best practices and of the types and number of visits required in a patient's care pathway, which obviously serves as a barrier to facilitating that transfer of care. And finally, limited resources were often cited as a barrier because it makes it difficult to train and hire enough employees who can oversee services and patients and ensure that this care is continuous. So moving on to the more positive findings, so several facilitators were also identified. So having local referral pathways, so this would be keeping services within the care pathway in close geographical proximity to one another, was identified as an enabler. And finally, involving Aboriginal health workers in care was also identified as a facilitator for this question as well. So ultimately, these two rapid evidence scans address the question of what's out there and what's effective in terms of diabetes programs and transfer of care initiatives for Aboriginal and Torres Strait Islander populations. So these syntheses of research can then be used by the ACCN to inform the design of new programs or modify or scale up current programs that are promising. So that's it with the work that I completed with the Knowledge Exchange team. I'm going to move on to the search project. But before I talk about that project, I just wanted to give you all a brief background of what search actually is. So search, like I previously mentioned, stands for the study of environment on Aboriginal resilience and child health. And it's Australia's largest long-term study of the health and well-being of urban Aboriginal children. And it essentially helps to address a large gap in Aboriginal health research, which is the fact that while 57% of the Aboriginal population lives in urban areas, it's estimated that only 10% of Aboriginal health research focuses on the needs of this population, and even less on childhood, which is where health inequity often begins. And this is because the majority of Aboriginal health research is actually directed towards people living in rural and remote regions. So there's a common misconception there that that's where the majority of the Aboriginal population lies, but it's actually in urban areas where that happens. So working as part of search are 4 Aboriginal community-controlled health services, which are basically primary healthcare services initiated and operated by the local Aboriginal community to deliver holistic and culturally appropriate healthcare. So this type of partnership research that search essentially models strives to engage Aboriginal people as equal partners and leaders, and ensures that the findings generated will be relevant to the unique needs of the Aboriginal communities involved in the work. So with this in mind, I worked on a plain language community feedback report for the Tharawal Aboriginal Corporation, which is one of Search's 4 partnering ACCHs. So this report summarized all the study findings thus far, which pertain to the social and emotional well-being of urban Aboriginal children. And it was actually one of many summaries of search data and local feedback that are provided to ACCHs on a regular basis to seek their input and streamline the development of new programs. And this constant and open communication of research findings back into the community-controlled health services helps to support the sustained partnerships between Aboriginal communities and researchers. And these reports also help to ensure that ACCHs can effectively understand and use the data to improve health, advocate for increased funding of evidence-based services, and direct future research priorities. And this really demonstrates the value of partnership research, where Aboriginal leadership and building community capacity to use and understand data in an established partnership like this can drive such meaningful improvements in health outcomes for the populations involved in this work. So now that I'm done with the work that I completed during my internship, I'm going to move on to the more personal experiences of my trip. So in hindsight, I realized that the value of partnerships became apparent during the hours I was in an office as well, which is actually a lot of hours if you think about it, because if you're only working from 9 to 4, you have 17 hours left in the day to do whatever you want. So that's just like a bonus of, oh, I guess like the 24 hours in a day, like you would have it regardless, but I mean, just wanted to put it out there. So for me, I love distance running. I've been involved with this sport in a few different ways for half my life now, but never have I been able to use it as a way to find companionship, comfort, and familiarity in a country where I came in knowing no one. I connected with a lot of the city runners during the week, and they showed me around and we hung out, but I think the most exciting personal experience was meeting a huge ultra running community up in the Blue Mountains. And for those who haven't heard of this sport or maybe aren't too familiar with it, it's basically like these honest, low profile, and very authentic people who train for and run races that are longer than the traditional marathon distance. So you have your 50 kilometers, your 100 kilometers, 100 milers, just a few of the more common distances. So it was definitely like a unique and magnetizing space where I felt like a lot of things were possible. And I ended up really bonding with this one family that loved to run. And during the weekends, I'd just stay over on the mountains with them. And they lived in one of 2 houses on Mount Victoria. And we just ran and raced with the mountain running group. So these are just some of the loveliest and most warm-hearted people I met in Australia. And by the way, the lady in the pink t-shirt, she's on it's like the bottom right photo over there. She's 68 years old and she's training for a 50-kilometer mountain run. So I believe that it is never too late to chase after something that you're passionate about in life. Okay, just my 2 cents on that issue. So yeah, the mountain running family, and they call themselves the Clumpet clan, by the way, and they call me Chloe Clumpet, and then they like unofficially adopted me, so yeah, I was like fine with that, and that's like the title of the slide. But we'd often go camping before the races because they were held in these remote, but I guess like just some of the most beautiful places I've ever seen in my life. And I saw lots of wild kangaroo, wild wombats, and a wild opossum down there. And you can see that it's this was the opossum stealing our garbage at 3 a.m. and hijacking a wombat hole. And I wanted to stay up even later just to see if like the wombat would come out and seek revenge, but I fell asleep. So, I'm just like truly grateful for these wonderful people who are so willing to help and share their playground with me when I was feeling scared and a little bit vulnerable. So going forward, I'll always remember what it feels like to be helped out in that way. And I will always strive to be that light for other people. Okay, next slide. Yeah, so besides running, I also practice sand dune quad biking in Port Stevens, and I don't even have my G2 yet, so this was a huge step up. This is like practicing. So surfing at Bondi Beach, which is a lot harder than it looks, by the way, but it was like still a lot of fun. And I also helped a fellow Kiwi scholar by the name of Fanny practice her photography skills by being her dance model. And here's me practicing various tricks across several locations in New South Wales and Gold Coast in Queensland. So yeah, that's it. But, So what's next in Chloe Gao's world? So my goals, okay, so these are just some like lighthearted, or I guess like my life goals, so not too lighthearted, but apply the personal and professional experiences I've gained through QES to my life back in Canada and see how I can work towards addressing similar health and social inequities more locally. I'm also working on integrating my child health educational background with my interest in the field of health systems and health policy. I'm not too sure exactly how that looks yet, but I'm working on it. And last but certainly not least, just like my Clumpit clan, who were just happy and present and would just keep running and running like nothing was stopping them, I want to run long, run free, and run happy towards all my goals in life. So yeah, that's it for my future. And finally, just a few very important acknowledgements here for all the people who made this possible. First, I want to thank the McMaster Health Forum and especially James McKinley over there for all their support and guidance over the years and for helping me grow into the person that I am today. Next, I wanted to thank the Queen Elizabeth Scholarship Program because I wouldn't have been able to experience any of this without their willingness to invest in youth. And finally, I want to thank the Sax Institute for hosting me. And yep, that's it.